Perfect. Yeah, people are here too. Hold your eye out. We only did. I've really got. We can probably get started when you guys are setting up and do the intros and stuff. If you guys are okay with that.
Yeah, thanks again, Chief. We appreciate it. Yeah.
Thanks, guys. Okay, we'll go ahead and get started here, everybody. Just want to thank Kris Jenkins from Salt Lake City Fire, and he's also works as a family nurse practitioner with Lone Peak and St. Mark's. We're glad to have him here chat with us about capnography, end-tidal CO2, and some sepsis. So with that being said, Kris, you got the mic. We'll turn it over to you. And all those online, if you wouldn't mind, please unmute yourself and ask any questions during the process. We're kind of short on people here in the classroom, so your input is vital. So reach out and ask questions, or you can even chat them on the phone. Thank you.
Well, thanks everybody. A little bit of my background. I've been a firefighter, paramedic for about 14 years. Started the first half of my career was in Ogden. Lateral Salt Lake about 6 years ago. I've been about 10 years ago. I went to nursing school, predominantly in the cath lab, but I did work in the ER and ICU and PD also. And then I've been a nurse practitioner for about a year. And yeah, I worked at St. Mark's and Lone Peak in the emergency department at that level. So a little bit of background on this class. Probably about 7 years ago in Ogden, I started teaching this class. It actually started because of the cath lab. We were going live with end-tidal to monitor, and the full SEPSIS using end-tidal came out. So I started teaching it. I've been teaching it ever since. Usually gets a pretty good response. There's some things that we probably don't think about a lot when it comes to end-tidal. So hopefully, when it's all said and done, you guys can get something out of it. Is there a way to?
Yeah, is it not moving for you? Okay, there you go.
Yep. Okay, so this is kind of the more objectives than anything. I like to teach end-tidal in a whole different way than what we probably learned in paramedic school. It's a better way that I kind of understand it. And then when we use it, who we use it for, they talk about the waveform, and then how we can use end-tidal to guide certain treatment. Then we're going to dive into sepsis a little bit and kind of how important it is. Okay, so this is, I guess, the definition of end-tidal or capnography. Capnography is the waveform that's measuring our exhale CO2, right? So what carbon dioxide is, and this is kind of where I think it's important to start thinking of end-tidal. Carbon dioxide is a byproduct of metabolism that's transported via perfusion to the lungs and then ventilation. And then end-tidal is the actual waveform that's telling us what that is. So there's three phases of capnography. I think what traditionally we think of it as just a respiratory or a ventilation measurement, but it's actually starts with metabolism, which is monitoring metabolism, then it's monitoring perfusion, and then our end product of ventilation. So it's a three-phase process that we want to kind of understand and use. So this is the metabolism, and we don't need to, I've learned the Krebs cycle probably 5 or 6 times in my life, and I forgot it 5 or 6 times. So it's not really, I'm not going to dive into it. There is one portion of it that I have remembered that I think everyone should kind of understand. And that, so aerobic metabolism, healthy person, enough oxygen, our byproduct of that is carbon dioxide. So when we're healthy, at the end of the cycle, we have CO2. When we're not healthy, or not necessarily healthy, but when we exceed our demand, our oxygen demand, we go into anaerobic metabolism, and our byproduct is lactate. So that's an important thing to kind of understand, and we'll get into why that's important when we're talking. So the perfusion portion of it, once that end product from metabolism has been created, that carbon dioxide, now it needs to be moved to the lungs. So through blood pressure, perfusion, it gets moved to the lungs to be expelled. So, if you have a decreased cardiac output, cardiac arrest, that end tidal number is much lower because we're not pushing that CO2 to the lungs. And then the third is ventilation, and monitoring both ventilation and respiration. So the actual gas exchange and then the amount of air that we're actually inhaling. So this is what we normally use it for, right? We're looking at how someone's breathing, how their gas exchange is. Those are the three phases we'll continue to talk about. Who should be on an end tidal? So right now, whoever's listening, and I have Murray here, right? Do you guys have the cannulas? How long do you use them?
Almost on every patient.
Awesome. That's the goal, right? My goal, and when I started teaching this in August, we went from ordering like 5 or 10 a month to like 100 or 200. Like it should be every patient, right? Especially ALS, true ALS patients need to be on it. Here's just a quick little summary. Carry arrest. Anybody who we think has the possibility to arrest. Respiratory distress is obvious. That's the one that everyone's already used for. Sepsis, we're going to get into DKA, which I'm going to talk a little bit about. Chest pain, trauma, stroke, obviously it's all there. If you do, anybody do critical care transport, like we're throwing anybody on a vent. Obviously it's a no-brainer to have them on. Sedation. So sedation is a little, I'm going to go on a little soapbox, but if we make the decision that we're going to sedate someone or give them almost any medication, we're also making the decision that we're going to monitor them. End tidal is the gold standard in the hospital, it's the gold standard in EMS. So anybody that we're deciding to give any kind of medication to that could potentially change their status, we need to be monitoring with end tidal. I'm going to talk about a carrier arrest patient real quick, and this, again, I think you guys, clearly Murray's using it, but you can have a patient that's really sick, you have them on an SpO2 and a cardiac monitor, say they go into a PEA arrest. How long does it take for an SpO2 change?
3 to 5 minutes.
It can take 3 to 5 minutes, right? And then how long does it take for a PEA to go to AFib? 3 to 5, 10, whatever. That's all time not on the chest. That's all, that's a big deal. The second they miss their first breath on end tidal, something's wrong. So that's why it's a huge deal to have all these carrier arrest patients on it. So here's the waveform. And we are going to talk about waveforms and how it can guide our treatment. So the end tidal is where that circle is. So we have this inhalation, this deep exhalation, right at the point before we start to inhale again, it gives us that peak CO2 number. What's the range? 35 to 45. 35 means less CO2, 45 means high CO2, right, or higher. I don't know why, but in paramedic school I had a hell of a time trying to be like, hey, wait, I don't know, now looking back, I don't know why I'm so confused. I'm not the only one that has that confusion. So we're monitoring CO2, and I think just that simple understanding is easy. I means there's more, so it means there's less. I think when we're talking oxygen, it just kind of confuses a little bit. And here are some basic waveforms. This shark tooth, or thin, I guess. Does anyone have kind of the understanding what's going on in that patient?
Yeah, they're having a hard time exhaling.
Perfect. And then all of a sudden that drop off, right? And we'll get into why that's a really important thing to kind of recognize in a respiratory distress patient. Hypoventilation, this can be from over-sedation, this could be end of life, but it's just the deep, long, but regular waveform, right? It still looks clean, it's just really prolonged. Hyperventilation, same thing. You're just seeing it much quicker, but they still look clean, just high rate, and obviously you're gonna see this is above 45, that's below, you know, if you're breathing fast, you're breathing off more, if you're retaining more. And then this bottom one, this is a good example of like, where we give someone 100%, they have a broken leg, and then all of a sudden, it starts getting kind of wonky, they hold a breath, and then all of a sudden it shoots up high. At that time, we should start considering, do we want to do a BDM, do we want to get supplemental oxygen? One thing I refuse to do is give someone Narcan that I've sedated. Like, I can bag anyone to the hospital, but I've decided they need pain management. Why am I going to reverse that? So these are, yeah, obviously basic waveforms that we'll probably see. Cardiac arrest, this is, I feel like, kind of the main reason they gave us this in the first place for ETCO2 and cardiac arrest. So this would be that PEA arrest I'm talking about, or any arrest, but where we have a normal breath and all of a sudden it's kind of flatline. The second one here is effective CPR and ineffective CPR. You guys use that pretty good, dictate how you doing. So Dr. Youngquist, he's my medical control doctor at the University of Utah. During this part, I had a question last week in Salt Lake. So like, well, what if they've been down for a long time? Is it even possible to get that end title up to 18? And he said they did a study, and he actually sent it to me, so I read it, on cadavers that have been dead for 72, 26 hours, they were able to get end title to 25 on quality CPR. So there is retained CO2 in a dead body with quality CPR. So be aggressive with it. If your end title is 8, 9, something's wrong. Hand placement, whatever. But it's a reliable tool that needs to be used. And then this last one, what happens when we're doing CPR? We see a spike in end tidal up to 70. Not wrong. Another cool thing, I don't know if it's not cool, I guess. Another tidbit that Quest told us is our pulse checks are crazy ineffective. Like, we are horrible, and it's not just us. Doctors, hospitals, pulse checks are just not reliable. The spike end tidal is huge for us to determine what's going on in the patient. Yeah, if we aren't feeling a pulse, but we have a high end tidal, there's more to investigate, right? For sure. And if you don't have it, yeah.
I have a question. Do you notice you write mainstem and innovation that the end title comes out of whack as well?
Yeah. Well, then and we'll talk. That's 100% true, and you'll get into innovation and stuff. But yeah, once we innovate, this tool is our kind of our lifeline. And I'll get into this, and this is a Salt Lake thing, so I wouldn't like big deal if you guys don't do it. But I'll just say it now. Again, Dr. Youngquist says if we don't have an end title waveform, we do not have a tube, and we do not deliver. It's pulled out. Even if are like super confident in it, and we've had some experiences that have proved to, I mean, that's a hard thing to swallow as a medic, I understand, but he feels that strongly about it. And a quick story with it, and again, I'm going a little ahead of the class, but we had a crew that used end title. They delivered the patient, they move them over to you, and then the tube was out in the esophagus, and they gave them a hell of a time. And they printed off the code summary and title all the way to the hospital, and they apologize. So I mean, it is something that's there to protect us and the patient. So, and I think that was one of the reasons he's like, yes, if we don't have it, because what happens if you do have it, you're super confident, the title is just not working, you move that in the esophagus, then you have nothing back to you up. They're not going to see you. So we're here with that. But when you talk about so abnormal waveforms, like something's wrong, not just the monitor. I know a lot of times you like to say, this thing. But there is more going on. Have you inflated the cuff? Do they have a pneumo? Are you rising stems? Are you in the esophagus? And then obviously use it in your tool. We don't want to hyperinflate the lungs in any scenario. We know that decreases cardiac perfusion, that creates pressure on the lungs, the heart, everything. So we're just watching that end tidal as we ventilate. So, like I said, a good clean waveform means you're in. There's no place where it's going to be clean other than the lungs or other than the drain tip. So we have the cords, and I'm sure you're using video scope now, right? That's kind of the standard. We massive visualization. And I've even, like when I've had some issues, I have dropped it back in, looked at the course, still in, and tinkered with the, do you guys carry, we have like the rescue pod, the filter. So I mean, sometimes your BVM's like all the way up here, you know, so many things off the ET2. This was a question asked them, just, that needs to be the first attachment, right? In our mind, it can't be accurate if there's attaching different levels of attachment to the. Okay, so let's get into some of the, like the treatment, what we're using N-Title for. We have respiratory distress. We talked about the waveform. How many of our patients have COPD and CHF? Is it just one or the other?
No.
No, right? So when I talk about dictating like your treatment using N-Title, we talked about the sharp. What's the difference in treatment between those two illnesses?
CHF, you're going to give nitro and CPAP, and the other one you're going to give nebulized treatment.
Yeah.
CPAP if you need to.
Right. So, I mean, that's the answer. In Ogden, we had fancy vents. Like, they were awesome. So I could say, if I had a COPD patient that was super sick and bad, I could consider putting them on BiPAP. If I had the option to go on like a 1 to 6 expiratory, like I could change the BiPAP to extend the longer period of expiratory phase. We don't have that now. I have just generic Venturi principal BiPAP now. What do I do if what could I potentially do to the patient with COPD if I put them on BiPAP? With just a generic, not any true.
Breath statute, lungs.
Yeah, exactly, 100%. So we have a patient that has both. We put them on N-Title, and it's not this. It's prolonged. What is the number one treatment? It only has BiPAP. We want them on BiPAP. So it's a huge deal for the best outcome of the patient, because those two things are different treatments, and that waveform is going to tell. I mean, obviously, our clinical judgment, are they wet or are they wheezy? I mean, those things play a role, but this is just another important tool to help guide. Well, no, this is a CHS exacerbation opposed to a COPD. And hyperventilation, like you said, especially with the history of COPD, we don't want to give more oxygen, or especially forceful oxygen that's necessary. So as we're watching those waveforms, it's helpful. Like even out in a lot of cases, on especially bronchoconstriction, hypoventilation is more important. But yeah, and like you said before, we hyperinflate that chest. We're dealing with a lot more now than just a respiratory problem. Now we can be dealing with cardiovascular problems, even creating new ones. So DKA, let's go back to the metabolism portion of COPD, of N-Title. What did I say? Just byproducts. What are we measuring? CO2 or lactate. Okay, that is true. What happens in diabetes? What is the case? Yeah, so ketones, right? So the byproduct, and this is why I'm bringing it up, is ketones. Are there a lot of them? Who smelled the fruit on a DKA patient? So what's the N-Title going to be on these guys? Be low because it's breathing so fast. That's part of it. So it is. It's two phases. So the metabolism in a DKA patient is off, and instead of creating a bunch of CO2, they're creating ketones. And then our body's response of this isn't right, let's get this out as fast as we can. Take that pH level, change that pH level. So I've seen 4, 5, 6 on these N-Title, and that's in a sense that guides treatment because they need fluid. A lot of times these patients need to be on a cardiac monitor, right? So I've given albuterol, I think 3 times pre-hospital to push potassium across the cell. Not part of our protocol. You have to be really articulate if you're going to call the hospital to do it, but it does work, and it's based off of like a peak T wave. So if I have an N-Title that's super, super low, and I have peak T waves, I'm pretty sure their electrolytes are completely off, and I can feel safe doing an intervention like that, just to see if I can prevent like an arrest or something.
Did you do a 4 or 12 to monitor that now?
Well, I mean, I at least have them on a 4 lead because you're monitoring them. If they're a 12 lead is going to give you more information, but I've always used them on a 4 lead. Yeah, like again, the PQ waves they're one of those things you put on, it catches your attention immediately. Like, oh, so, but I think we get pretty lackadaisical with DPA, not realizing that a cardiac monitor, bilateral IVs, and an end cycle are all valuable data that we should be collecting. And I just want to, so what's the difference between DPA and ETCO2, which is the type 1 versus type 2 type?
Whether or not it's burning fat in order to get the high income.
Yeah, and so with someone who's an HHNS, they're type 2 diabetics, they're not DKA. How many times do we see someone with sugar of 7 or 800? The chances are, if they're type 2 diabetic, that they're not high in ketone. However, and this is all due in, this doesn't have to do with the antibiotics. The mortality, what is more likely to kill you, DKA or HHNS? It is. And I went down a rabbit hole for hours trying to find the reason. And I came up with my own solution or answer. And I talked to a couple doctors, like, yeah, that's good enough. I don't really care. But I just think these type 2 diabetics are so sick. Like, type 1 tends to just be something that luck of the draw, sorry, take care of yourself. Where type 2 is almost earned in a lot of cases. I don't want to say that. You know, I know there's a genetic component, and I know there's more to it. However, lifestyle choices, and they tend to have more like hypertension, high cholesterol, whatever else they have with it. So I think that was just I think when they get this sick, it's more their comorbidities that kill them. I could be wrong.
Does fluid depletion have anything to do with that?
With both of them, they're both dry, and that's why the end title is just telling you, yeah, they're DKA versus they're not DKA, but treatment same for high sugar. They're dry. They're going to need a slow dose of insulin and electrolyte balancing as they kind of lower. So, yeah, I mean, again, not super into end title, but is there any questions on there? Okay, so trauma. Again, back now we're to the perfusion portion for CO2. And there is good data suggesting as we have like a good trauma where we're considering hypovolemia, dictating our fluid resuscitation with end tidal is helpful. Obviously, math is still the standard. We want that math at 65, and we want to be permissive hypotension, right? We're not going to overload these people with fluid. We don't need to change the blood concentration and all that, but we do need to do it. And so I give fluid, end tidal is another reason, not only because they're perioperitoneal, dictate if we can elevate that end tidal for more likely if you know your map, you're going to take it every 3 or 4 minutes, or as much as you want. That end tidal is real time data. It's happening every breath. So, and then when you talk about TBI and CO2 levels, have you guys ever read about like hyperventilating the patients? Well, there's data that suggests that too much can do damage, and then too little is bad. So your end top, if you can, what's the range?
How much should for the lower limit of like 35?
That's normal, right? So if you can hit 35 and just keep them there, then you know you're not hyperventilating them or hyperoxygenating them, but they're still decreasing that CO2 level to cause some vasoconstriction to protect the brain tissue. So it's a good way to dictate your oxygenation during the trauma. These are the references. You believe me. There. Okay, so this is the second part of the class. This is where, so when I started this class, it was 10 years ago, this was a new concept. I think where we're at here 10 years later, this has caught up to people are using it for this, but it's still really cool to understand it and talk about it. And I mean, it's like, well, this is why. So this first article, we're known, as EMS, we're known for 3 things typically: STEMIs, strokes, and trauma. How often are our conferences about trauma? That's what it always says, right? Well, we see more sepsis over a year than those three combined. More people die in the hospital because of sepsis than those three combined. Our whole goal as EMS is to make a big difference, to do whatever it takes to improve patient outcomes. So this sepsis really is the fourth pillar now. Not saying those three are all super fun, and I love all of them. But this is our fourth pillar where we make a huge difference. We have the Cincinnati, which makes a huge deal, right? We go straight to CT, we have thrombectomy in the IR lab, and we'll have TPA. That's us making an early detection of, hey, this guy's having a stroke. SEMI, the 12 lead came out. We're bypassing the ER completely to get to the cath lab and have 4 balloons in 40 minutes. Huge deal. Trauma, we have 10 minutes on the scene. We're there, we're out, we have golden hour to get them to blood, to surgery, whatever. We make these huge differences based off these metrics that we've drilled into our heads for the last 30 years. Well, with sepsis, the only link to survival is early detection. Now, as a nurse, as an ER nurse at some point, there's been several times where we get our labs back an hour and a half later. It's like, oh, they're septic. Yeah, so we hurry and we give them an antibiotic. We didn't take culture. So there's all these metrics in the hospital that we've missed because we didn't find out in the first few minutes. And I come from, so Ogden and Salt Lake both have an ALS, BLS system. So we go on as paramedics separate. We decide if it's an ALS call, if it's not, we give it to the DLS ambulance and we go. Unfortunately, that leaves some laziness, like, oh, yeah, their pressures are a little soft, but I can sell this, I can sell, I don't think. So I paint a picture that this patient may not be as sick as they don't need ALS. Again, as a nurse, I see a BLS crew come in. I'm like, no, they're good. We'll get there in a minute. And I go in there and I'm lackadaisical, get the labs back an hour later, and I realize they're septic because an ALS crew comes in there because I think they're sick. They don't kind of downplay that story. We get the labs and it moves forward. So end title now, this is a long story, very long-winded with all this stuff, but again, I think it's important. End title is a very high predictor of lactate. From what we know about metabolism, why is that the case?
The anaerobic metabolism, not enough oxygen, or lactate, or on the other, or lactate. 100%. So our pH is off, lactate is low, or lactate is high. So what's being moved to the lungs instead of carbon dioxide is an excess of lactate. And our body again recognizes that, starts to breathe a little faster, and so our end titles are lower. When you bring in an assessment tool, so like the Cincinnati, but for sepsis, which we call Sears criteria, we're all aware of, and we'll talk about QB protocol. But you have temperature, known infection, heart rate, blood pressure, respiratory rate. You get 2 of those things, and an end title of 25 or lower, it's almost 100% positive for sepsis. And it's actually equivalent to a level 4 lactate, which has a high mortality in a patient. So now, when we call a hospital, we don't say we suspect that. We have telling us, hey, I'm calling a sepsis alert based off of this. Now, we've struggled over the last 10 years. I've struggled getting that to the hospital. I go in there and say, end title 22. Why are you telling them that they're entitled? They don't even care. That has been the process of changing. Is this coming out? QB protocol has accepted this as fact. You can use end titles to help diagnose sepsis. Now, again, we're still clinicians. Do we need it all the time? No. We go in, pressure 70 over 30, heart rate's 150, and they have this nasty another leg. It's sepsis. We know that. This is just, again, it's the same thing with a stroke. You go in there and we're still going to use all of our tools and use our skills to tell the hospital sepsis. So on this bottom study, just EMS using the word septic, and it wasn't based off of end title, it wasn't based. When we called and said this is a septic patient, I can't remember what the study was done. I think California, but it could have been Medical in Washington. They said if EMS calls a sepsis alert, everything has to be done, regardless of what you think. And that's like us calling a STEMI and then them going to the cath lab. Kind of a big deal. They'll never do that for us in the cath lab, but they will. So they did this with the sepsis protocol. And what that was is you have these like these core measures. You have to take cultures within like 15 minutes. You have to give antibiotics within an hour. You have to do all these things. There, when they had to do it based off the MSA and sepsis, their core measures went from 60 to 90%. So they only meant, so they improved 30% on actually getting those accomplished on this patient. Okay. And then the mortality rate improved 24 to 45%, which is drastic. And those, like I said, the only link they found for sepsis is early detection. They haven't found anything else in the survival of these patients. We are that link. That's huge. And so when I go back to the three other things that we're known for, this is where we're going to make a ridiculous impact. If this becomes just habit. And sitting in one of the physician meetings for the hospital, they missed, like, it was like they missed 8 or 9 septic patients. Almost all of them were there for another reason: trauma, stroke, and STEMI. So those 3 patients need, if they're still fitting this criteria of sepsis, we need to recognize it. Because if it's a heart attack, that's still a priority. But giving them a shot of antibiotics is not going to hurt them, and they're only going to do that if they're sepsis. And if we can catch some of this stuff for them, because they're not thinking that, we need to be thinking that on every patient.
So maybe we can point out to them, when they call sepsis, you can call sepsis ward right now. What are you going to see different at the hospital? Okay, with trauma, you get the trauma team. With stroke, they meet you at the scales in the ambulance bay. With the STEMI, they're looking at you 12 weeks and trying to get the cath lab going. With sepsis, you're going to get the regulars, nurses, and the doctors maybe on point. But what's going to happen is that quick change into where they're starting to draw the labs. They're getting the order put in place to do this. Some things they're going to need from you is to know when you started your IV and how much fluid you've given them at that point. Because that's going to all play into what their treatment is. So it's not going to be the big sexy, right?
Yeah, it's not as exciting as.
But it's important.
And they will be over yet, like him, and I noticed this on these obvious. The U does it a lot. You tell them, like, especially like soft pressure, but they're critical, they're on top of you. You're getting it before you're even getting reports. They're on blood. These core measures are such a big deal. But you do see more of an urgency than you used to on these sick patients, which is reassuring for us. Like, okay, they're taking us serious. They're going ahead. But so this is just, these 3 articles are kind of pretty awesome, showing our impact on sepsis, and they are linked to Entitle and using that as a tool. So our treatment, like you said, what are our treatments for sepsis? So we go on this guy.
Fluid bolus, Entitle, and then if it doesn't bring up the pressure, like an everyday approach.
Yeah, perfect. Exactly. And then our golden number of MAP, I wrote up again 10 years ago. And everyone thought that was so cool, but we all have souls or life hacks, right? Number of the circle, keep it above 65. It's that important.
Let me ask you another question.
Yeah.
Is there any correlation between LR is more important than the isotonics that we use?
Yeah, so there is a lot of, like, I know certain hospitals concentrate LR and they've gone back and forth. I personally don't think so, and I might, what we use is going to be good. Like Ross said, one of the most important things is when we start, how much we've given, because there is a formula for that. And as far as LR versus NS, I don't think it. I personally just give what I have, and they need fluid. They're dry. I have had a bad, and this was part of this. This is one of the big questions. What do we do with someone like severe heart failure and they're septic? Not septic, they could be septic for something else. I mean, heart failure patients have poor perfusion. They get pneumonia pretty easy. They get wounds, like they'll get distal wounds that become infected. So what do we do when they're clearly septic and they need fluid?
Sometimes people flood the crap out of them.
Yeah, so we don't know. I mean, sometimes we can have some awesome information, like their EF, which is their ejection fraction, how strong is their left ventricle sending blood throughout the body. If it's sub 25, like it's critical, we can kill them. Unfortunately, I've done it. So not in the hospital, in the hospital, luckily. I think. Well, I mean, it's in the hospital. No, for real, it was horrible. And it was, we were told, regardless, given the fluid, what I would say is they need fluid because they're still going to die. It's just one of those where end title, just to make sure that we're sitting in a good, like, see if we're improving it. If they're septic, it's going to be low. But see if we're improving that end title, but lung sounds, SpO2, it just needs, those patients need so much monitoring that, I mean, that's what we should be doing anyway, right? Everybody deserves our best, our full attention. But these people, if we're going to give the fluid that they need, there needs to be a stethoscope on them almost constantly. And we just need to make sure we're taking care of them. But they need fluid, and their ES may not support it, and it's, you know, so it's just one of those, as we make those decisions, we need to be very diligent in our care.
And light it up and don't wait around.
Yeah, 100%. Most of these patients, I mean, a 1039 on these is completely acceptable in my case, because we just said early detection, early treatment. The answer, we're only giving part of it. They still need their antibiotic. They still need probably better pressors than epi. You know, we don't need it, but they probably say they need it. So this is, I told you Sears criteria, which is systemic inflammatory response syndrome. 2B has gone with the two or more method. So, which is the same thing. So you need to think about ET, temperature, tachycardia, dyspnea, ETCO2, and then mean arterial pressure, 65. You have two of those, and then one of these risk factors, again, you're going to be calling it up. Now, some of these are really important to think about. Honestly, I'm to a point now, 14, 15 years or whatever, every alternate elderly patient has UTI. So pretty otherwise, like they're UTI, or a stroke, right? You want to go down both routes. But, I mean, there's, especially those females, there's such high risk for UTIs, and then the way that their body responds to those. And it could take some time, and then these nursing homes miss that for a week or two. Super easy to become uroseptic at that age. So again, low threshold for thinking uroseptic. So the one, somehow wants to think fatigue altered, but like that to me, an altered is another one of those things. People that are immunocompromised, obviously. Anybody with an indwelling catheter, wound, type 2 diabetics, constantly are at risk because their blood, that sugar that's kind of high is just a perfect place and for infection to grow. So if someone has type 2 diabetic and then you get their sugar at 250, it's probably always 250 or 350. So there's a chance for some form of infection. Obviously the wounds, the recent surgery, people that aren't moving around a lot. Again, they'll see it, the VHF patients are people with venous deficiency that have like this weakly movement. It's such high risk for infection. So just those things, little kids, think about the extreme ages. We want to have, like I said, we want to have a low threshold on sepsis. Here's our 2B. Now this is the shock and fluid, because when you look up sepsis, it just says the shock and fluid. So, how do you guys run? Is it ALS ambulances? Okay. Yeah, and so I mean, in that scenario, you get you're going to the hospital anyway. You might as well and there's no reason not to just get into the plan. So, but this is everything we talked about. We're doing fluid, we're keeping track of it. We're doing 12 leads. A lot of times, the reverse is true with what I said when they miss like the stroke, trauma, semis. When you're sick, those things happen. So you're already septic, your body can throw a clot, that's not uncommon. So if they're so septic now that it's masking like a heart attack, again, those people need to be monitored for that too. And every patient needs to be on a cardiac monitor, totally completely reasonable, even without chest pain, especially women, diabetics, we find on this closely. And then obviously just monitoring electrolytes with these people. They can again, what do you use? What's your what is your pressure?
We start with the push dose and then transition into an 1 milligram and 1 milligram.
Like the WFE, right?
Mhm.
I know some people, and I think some people are trying to keep Terry Levo. I think Leighton is. We use dopamine, which all of these. In August we did. I don't think they do anymore. I think they've gone to the but I mean, again, from a cardiac background, dopamine is pretty awesome in like post-rock. Yeah, so it's not like we only use dopamine, we don't even do it dirty FE. I actually like it. You watch that cure start to wide and there's a CC in there, get comfortable with it, have a lot of confidence, get your fluid, obviously our goal is patient outcome. So I think that's all on this slide. We can talk about anything you want about this. If there's any questions or comments, stories about
How
using it.
often do you think we don't appreciate the blood pressure? Because I've seen people that 115, 118, and other people like, oh, that seems all right. It's just like,
Yeah.
there's something off and the map's still low and they're still tachycardic.
Yeah. Well, 100%. I mean, I think a lot. I think the old, and again, they're all, it looks like we all probably have different years when we graduated. I remember thinking sepsis was low blood pressure. Like, and I don't know where I thought that or what kind of when I started. That's not the case. Like, that's a bad late. We want to catch these people earlier. Tachycardia is probably going to come first. But what if they're on a beta blocker? Like, and their heart just doesn't. These people that are septic, how common is it for them to be on a beta blocker or an ACE, or not an ACE, but like a calcium channel blocker, something that's controlling a rate. That so now they're not hypertensive yet, but they're not tachycardic either. I mean, we need to have that low threshold. We need to be better clinicians looking at like the whole story. And I mean, we've all fallen into it. And again, I've been in those systems where at 3 in the morning, I'm like, God, can I tap this off the field? Like, that's complete BS. And so, like, I mean, that's my thing. Like, I try to, where I work now, that is one of the things that I try. I had the benefit of being a nurse, I think, just because I got to sensitize myself more to their side of it, just like they need to ours. Like, we're at times so far off, but we're on the same team. But my big phrase now that I like to use, I would be told, like, well, if they're not dying, so like, what difference are they're gonna, an IV now is not gonna make a difference in 5 minutes. Probably true. However, so I needed to come up with a good answer, and I think I have it. It is the ALS report. Our job is to point the hospital in the right direction. If I am passing something off as BLS, that is going to be their approach. And so if this patient is sick, my ALS report and the fact that I'm just there changes the way that they respond to me. Luckily, well, I mean, it's almost harder for you because you're coming no matter what. So now your report has to be solid. There has to be a lot of confidence,
And I know sometimes that's hard for us, and you guys can get frustrated stuff. We'll go to, say, a care facility, who the nurse goes to get paperwork, never returned. We have no idea other than the vitals. We have no idea how long they were like this, what their story is, other than we see wound back, see this, but like we can't gather much information without them, and they disappear every.
Right. I mean, again, I'm still firefighter. Still, like, I've gotten in trouble and I need to get better, but I will snap. Like, I don't care if it's the first time you have a patient, you accept the patient being an issue. So tell me something. Like, so, I mean, and again, so it does fall on our clinical judgment. They're not there to think for themselves. They're not. And so we need to, they call us for a reason, even if it's BS. We're going to go to the hospital regardless. It's not going to hurt us to find out whatever we can. And if all that is vital, and title it does kind of bring in that extra set of information that we didn't have. And we sell, and then, you come to the hospital and I get, now you're passing off your frustration to me, like, what do you mean you don't have it? Now we're blaming you, who's blaming them. I would understand it's their fault, right? But Yeah, I had another thought about that. Oh, so we have a paramedic student now where I'm working, and he keeps telling the patient, like, well, your vitals are fine. And I hate that now. It's like, I didn't realize how bad I hated that saying it. And so we had to talk, but he helped me kind of reflect on my own assessment. Like, if you're going to say that, tell them why. You know, I would be worried about your heart rate, but your heart rate's down in the 60s. So that's reassuring. Your blood pressure's up, you know, it's not down, it's not thinking of it. If you're going to say their blood pressure or your vitals are fine, explain to them why it's fine. I mean, that was just another, this is a new thought. We're just going on rant right now. But like, it did for real. Like, vitals are one, there's three, in my mind, there's three. There's the patient appearance, story, and all that. There's the monitor, what it's telling us, and then there's the vital sign. One of the three are off, it's off. If they're saying they're sick, everything looks great, they're sick. Like, they're telling us something. We're not going to say, well, these two things say you're wrong. Like, I mean, all three have to, and then when all three are bad, those aren't patients. You're already going on. Yeah. But like you said, you can have normal pressures, you can have some normal vital signs.
Kind of going with what you were saying about the ALS report, I'd say it's probably about half the time I have the initial call for something else.
Yeah.
You show up and then through your assessment, like, okay, I think,
Yeah.
you called for a symptom, we're sepsis, we're going to go down that route, and I'm redirecting that to the hospital, saying sepsis first, and then they call for this.
Yeah.
Really get them on the right foot.
Yeah, for sure. And we can even stop blaming dispatch for anything, right? We all hate it. They don't tell us what's going on. That's where we live in. And I mean, I'm sure I would be a horrible dispatcher. They're only being told what blame them for whatever. The reason I say that is because that is the case. I would say at least over 50% of the time we have a septic patient, we're going there for some other reason. How many times fall? I would say a high level of vulnerability. Especially if they're normal, like if they're unable to get off the floor, or they fell for no reason. There's a reason. I mean,
Well, I got one more question.
Yeah.
What, aside from whether they get close sepsis or hot sepsis, I've never understood that. I can't find any literature that explains why.
but I mean, again, the extremes of temperature, just know the extremes of temperature, the extremes of pressures, the extremes of heart rate, they're all can lead to sepsis, right? Our job is just to be clinicians, do the best. So, yeah, I go down these rabbit holes, and then nowadays, like, opinion users help me. So,
Okay.
yeah, for sure. Yeah, thank you.
Any questions online? Unmute or chat. Before I
Good
let
job.
Chris
That
off the
was a
hook.
good answer.
Yeah, thanks.
Much appreciated.
Chris, I'm not seeing anything, so
Cool.
thank you for being here today. Thanks for those joining online and for you guys coming today. Appreciate you being here. We'll go ahead and close out our class. Have a great day.
Thank you, Chief. That was great.
I did my paramedic right. Please don't worry.
Did you really?